It's my distinct pleasure and privilege to welcome you all to the Delta Omega Alpha Chapter Centennial Celebration webinar. Today, we pay tribute to the establishment of the Honor Society in Public Health, which was conceptualized on 2 students' commute to the school, something many of us have forgotten thanks to the pandemic. Today's webinar will be the first in a series put on by Delta Omega Nationals. Every month, a different chapter will host a webinar about a different decade, taking us through the past 100 years. So please visit their website for the upcoming webinars. Here at Hopkins, we will be having upcoming Delta Omega activities as well. This includes a poster competition for students in March and a scholarship competition that will be coming up in April. Today, we have the honor of welcoming my esteemed colleagues to discuss post-pandemic learnings from the 1918 influenza pandemic to COVID-19. And I'd like to briefly introduce our panelists. Dr. Karen Thomas is the school historian for the Bloomberg School of Public Health. She's the author of several articles and 2 books, including Health and Humanity, a history of the Johns Hopkins Bloomberg School of Public Health. And she will be our moderator for today. Dr. William Moss is a professor in epidemiology, molecular microbiology and immunology and international health, and he's the executive director of the International Vaccine Access Center. He's a pediatrician by training and an avid historian as a hobby. Dr. Gigi Granval is an associate professor in the Department of Environmental Health and Engineering and works at the Johns Hopkins Center for Health Security. She's an immunologist by training and teaches a course on the 1918 pandemic flu if you're interested in learning more. So please join me in welcoming our panelists, and now I will hand it over to Dr. Karen Thomas.
Good afternoon. It's really an honor to get to speak to you today. There are so many parallels between the great influenza pandemic of 1918 and 1919 and the COVID pandemic of our own time. But I want to start with these 2 images of emergency hospitals. One during the 1918 pandemic, and the other is the Baltimore Convention Center Emergency Hospital here in Baltimore. And I think it's interesting to me how the lighting and the arrangement of the beds is almost identical when you look at the 2 pictures. And the reason why those beds are lined up the way they are, there's a couple of reasons. One, it's practical. It enables the medical personnel to easily get to their patients. But, and in the photo on the left, everything is completely open, and so a relatively small number of nurses could actually see all of the patients in the room at the same time, which made it easier to respond to people. Another interesting thing to note is on the picture on the left, the medical personnel, but not the patients, are wearing masks. So they were aware of, I think that was more to protect the medical personnel, but it also actually helped prevent them from transmitting germs to the patients, although they probably may not have realized that at the time. But our hospitals get this orientation of these straight lines from churches and from, so churches, orphanages, asylums, and hospitals were all arranged similarly because there was no electricity yet, so there were these, the daylight had to come in on both sides, and just the very efficient use of space kind of dictated these straight lines. So anyway, that's just kind of an interesting architectural note. But in the picture on the right, of course, although there's an attempt to for privacy, but also for preventing transmission. There's an attempt to have separate compartments for the patients. So anyway, I thought that would be an interesting way to start. So one of the most interesting public health methods to come directly out of the 1918 pandemic that is still in use today and was used during the COVID pandemic is the excess deaths method. And that was developed by Wade Hampton Frost, who is the first chair and professor of epidemiology at Johns Hopkins. But he was still an active officer in the public health service for the first decade he was teaching here at the school. And during the 1918 pandemic, he was called to, he and a famous statistician named Edward Seidenstricker did this mass survey and collected 111,000 surveys on households that were statistically representative across the country. And they found out, the age, sex, and number of people in the household, and whether they had symptoms of or, an active case of a disease that resembled the flu, because there weren't diagnostic tests. A lot of influenza cases were misdiagnosed as pneumonia. But what's interesting about this method is not only did they do this very statistically advanced for the time survey, they also went back and looked at the previous mortality rates to see what the baseline was. And so by showing the difference, it was 1.5 deaths per thousand population pre-1918, and then it was 5.5 during the pandemic. So that was quite a tremendous increase in mortality. And that method is still used today because it's very difficult to accurately count how many deaths there are during a pandemic, because by its very nature, it throws everything into an upheaval. So I thought that was worth noting. So because, of course, this is Delta Omega, I wanted to talk about why your organization was founded and place it into a larger context of the professionalization of public health. So both pandemics really highlighted how important public health was. And honestly, it was an excellent advertisement for public health. So if the history of professionalization generally, each new profession follows a lot of the same developmental stages and tries to accomplish a lot of the same things, which is to say, you set up schools, you found journals, you create honor societies. And so Delta Omega was squarely within that very early stage of professionalization of public health. And why an honor society? What does that do? It identifies the outstanding people in the profession. And Delta Omega also served as a professional network for its members. And it was able to link the brand new schools of public health that were then being established before World War II, because what's now the ASPPH was founded as the Association for Schools of Public Health in 1941. So Delta Omega played several very important roles in linking together and providing legitimacy for the entire profession of public health. So that's something that your organization should be very proud of. So when we look at these pandemics and the professionalization of public health, these pandemics really helped the public understand why they need public health in a way that almost nothing else could. And not very long ago, and I think I would imagine a lot of us are familiar with this, if you talk to someone at a party or whatever and say, I'm in public health, even 10 or 15 years ago, they might have said, well, what exactly is that? Is that like, keeping, because we used to be called hygiene. In fact, this school, Johns Hopkins, was named the School of Hygiene and Public Health. And hygiene in 1916, when the school was founded, meant the scientific research on the causes of disease and how to prevent them. And whereas hygiene now has a quite different connotation. But understanding what public health was, the basics of public health are count things, count how many deaths and sicknesses there were, educate people on how to prevent getting sick, and do environmental interventions such as washing hands. Just as a kind of a side note, it's interesting that so influenza and COVID are both viruses and are both spread by airborne transmission, correct? And just making sure. And people were not aware of that in either pandemic for most of the time. Even the WHO was very resistant to the idea that the COVID virus could be spread in an airborne transmission, in other words, across fairly large distances. So when we were talking about social distancing, it was useful, but if you're in a smaller space with lots of people, it's not that useful, especially, so you look at, how big a space, how many people, and how long a time are you there? So if you're on a subway car for like an hour with a bunch of people, it doesn't matter how much social distancing you do, or perhaps it does. But anyway, so there wasn't yet a clear understanding of what was directly causing and how it was being spread. And so public health had an absolutely critical role to play as the disease detective. They also, and I mean, in 1918, you didn't really need a reminder of how important infectious disease was. The mortality rates, even in the United States, were just extremely high. The leading causes of death then were, in addition to the upper respiratory diseases, were also waterborne diseases that wouldn't be prevented until widespread, indoor plumbing and sewage systems were implemented across the country. And that wasn't even really in place till the 40s or so. But in the 21st century, we did need a reminder. We were not thinking very often about the spread of infectious disease, and especially not pandemic infectious disease. These pandemics also served as an incredible teaching opportunity for public health students. And the very people who founded Delta Omega were students like less than 5 years after the pandemic had ended here at the school. And so the pandemic shaped our teaching. I'm going to go ahead and go to the next. So it jumpstarts the growth of Hopkins as a teaching and research center. It justifies the major expansion of public health. Several new schools are founded. I think there's 8 by World War II in the United States. We didn't even know how many deaths per year in every state in the Union. We were not tracking that in a national system until 1933, when the National Death Registration System had every single state. A lot of states had more difficulty if they were, a largely rural population, and also states that had very few local public health departments because there wasn't a consistent system yet until the 1940s. So in 1935, when we think of the Social Security Act, we think of, pensions for older people, but Social Security was like really the most important public health legislation of the 20th century. And it was why more schools of public health were founded, because there were federal training grants available, and also why more public health departments could get assistance and there could be a consistent network across the country. So all of those things really put in place the system that we had in many respects. Not everything was there, but a lot of it was there, partly as a result of the 1935 Social Security Act when the COVID pandemic hit. I'm sorry, I thought okay. Okay, good. So what can we see for the future? I think that the COVID pandemic showed that we have really an excellent ability to unite support for public health under emergency conditions. And I'm currently writing about the period between 9/11 and COVID and looking at how each of those successive crises affected public health. And it's like we just keep going through the same cycle over and over again, where everybody will say, wow, public health is really important, let's give them some money. And then only a couple of years later, it's back to the same, status quo ante. And so with COVID, I really do hope that we can actually sustain many of the programs and policies that were implemented during COVID, not only just in public health, but things like increasing the child tax credit to bring children out of poverty and things like that. But it's really hard to secure the ongoing funding, not just for different kinds of federal programs, but just the basic infrastructure of public health from the local to the state to the national to the global level. We are still behind, I think, even after COVID, with what really needs to be in place to be fully prepared for the next pandemic. I think it's possible, and I'm certainly open to being challenged, but I think the depth of public mistrust in science and in government and even in the health system was maybe the biggest obstacle that we faced during the pandemic. Without that trust, I think it was much harder to get the buy-in and the participation close to 100% on things like vaccination or even masking. Now, don't get me wrong, there was a lot of opposition to those things even 100 plus years ago too. It's not like it was completely, but there's just a really historically unique level of distrust right now, I think. So finally, I'll just close with schools of public health have an incredibly important role in filling the existing gaps and also making sure those gaps get closed. During COVID, Johns Hopkins stepped forward to provide accurate statistics when the CDC was both not able to, but also was told not to. So, we were also, our communications group here was doing a really excellent job of providing really understandable and very clear and up to date communications on COVID because things were constantly changing. And finally, universities, all of the institutions that all of you are at across Delta Omega have more freedom than government agencies. And the things that universities really excel at are being able to innovate in research and teaching, but also to really quickly adapt to new challenges. So I think universities and Delta Omega and schools of public health are definitely going, whatever is coming, we are going to play a very important role in addressing those future challenges. Thank you very much.
Thank you, Karen, and thank you, Andrea and Megan. And it's my great pleasure to participate in this centenary celebration of the Delta Omega Alpha chapter. So during the pandemic, I had the great pleasure of serving as the vaccinology lead on the Johns Hopkins Coronavirus Resource Center. And Karen alluded to that with the dashboard that provided the statistics that Lauren Gardner and her group started. And what happened during the pandemic is that we would hold, colleagues and I and Gigi participated in this, weekly briefings for the media and for the public on Fridays. And so it would be about a half-hour session. We would each get a few minutes, and then we would take some questions from the audience. And what I want to reflect on a little bit is how, and it's actually picking up on some of Karen's points. We want to build trust and foster trust in our messages, in our public health messages. But in a rapidly evolving situation, we don't always know everything that we need or want to know. And so there can be a tension between communicating confidence, communicating simple, straightforward messages, but also kind of allowing for the nuances and the uncertainty. So that's the theme I want to try to present to you very briefly today with this somewhat provocative title, What If the Science is Wrong? And I'm going to do this because my interest is in vaccines. I'm going to tell a little bit about the perhaps somewhat unknown story about the use of vaccines in the 1918 influenza pandemic, and then kind of tie that back to this idea of communicating uncertainty. So I'm going to go back even further than 1918 to 1892. And so there was there was a pandemic that probably started in Western Siberia and spread throughout the world, thought to be due to influenza virus. It was called the Russian flu or the Asiatic flu. And it resulted in over 1 million deaths, and the population of the world was much smaller then, about 1.5 billion. And this was really the first really well-documented pandemic. And it was during that pandemic that he was young at the time, but became a very well-known bacteriologist, Richard Pfeiffer, isolated a bacterium from the lungs of people with the Russian flu. And he called it Bacillus influenzae. It was often referred to in the literature as Pfeiffer's bacillus. And he published these papers initially in German in 1892. The pandemic actually started in 1889. Biggest years were 1889 and 1890, but it actually extended out into 1894. And this is a quote from actually another paper in the British Medical Journal. In view of these results, I consider myself justified in pronouncing the bacilli just described to be the exciting causes of influenza. And Pfeiffer was a protege, as you can see in this picture. So Pfeiffer's standing, that's Robert Koch, the famous bacteriologist who really was instrumental in founding the whole field of bacteriology. Pfeiffer worked with Koch. And so his pronouncement that he had discovered the cause of influenza carried a lot of weight. And so this bacillus we now know as Haemophilus influenza. So we know it to be an important pathogen, but not the cause of influenza. There were a few scientists during the 1918 pandemic who suspected that this was not the cause. This is a difficult bacteria to culture. And so when they couldn't find it or couldn't culture, it was often blamed on poor microbiology techniques. But there were some scientists who suspected this may be due to what we think of as a virus. There was very little known about viruses at that time. Basically, all that was known was that it was an infectious agent that could be passed through a porcelain filter and remain infectious. That would screen out all the bacteria and protozoa. So there was some hints. It wasn't until the 1930s that influenza virus was actually identified. So here now we're going to jump forward into the 1918 pandemic. And this is a clip from the New York Times on October 2nd, where Royal Copeland, who was the commissioner of Health in New York City, announced that William Park, who was a famous bacteriologist who led the New York City laboratories, had discovered and would soon prepare for general use a vaccine that would be preventive against Spanish influenza. And I'm just quoting from this article. And so this was obviously the Spanish flu. This, so far as the health authorities know, will be the first time that a vaccine had been employed to prevent influenza. And I put in some pictures. These are some photos from William Park's lab. You can see it. All women working in the laboratory there. So this was one of the earliest announcements of a vaccine against influenza, against the bacillus. And actually, vaccines against this bacillus were developed in many cities throughout the United States, in Canada, in parts of Europe. And used during the pandemic. And this is, there aren't many vials of this vaccine around, but this is one, a rare vial of influenza vaccine created by the Royal Army Medical College. So kind of looks like our vaccine vials, right? And as I said, many people were vaccinated. You can see what's interesting about this photo. So these are people lining up to get their influenza vaccine in 1918. You can see men, children getting the vaccine. And actually tens of thousands of people were vaccinated with this vaccine. There were some others who actually combined different bacteria into the vaccine. Well, we now know that this was not, science was wrong in this case. And I found a clipping from the New York Times 2 years later, where we still have Dr. Copeland announcing that experiments had demonstrated that all anti-influenza vaccines were worthless, and that the vaccine said to have been discovered by Dr. Park, director of the laboratories, and used extensively, will not be employed. This was during the third wave. So this is it's an interesting history of how science kind of, when the science became misleading about the actual pathogen, led to a public health intervention, development of vaccine that was then claimed to be worthless. So science is much better now, no doubt about it. And so, I mean, the story of the development of COVID-19 vaccines is really a remarkable one in terms of just the timeline from the time the pathogen was really identified and sequenced in early January of 2020. And then by the end of that year, we had vaccines that had FDA emergency approval, and by December, we're going into the arms of people. So no doubt, I think we got the pathogen right this time, develop vaccines. But it's still a complex, nuanced story. And so I just want to very, very quickly highlight one of the phase 3 trials. This is for the Pfizer vaccine. The lead author, actually, Fernando Pollack, he and I did our pediatric infectious disease fellowship together here at Johns Hopkins Hospital. But just to highlight a few things, vaccine efficacy, 95% in the phase 3 trial. Similar vaccine efficacy across different demographics group by age, sex, race, ethnicity, presence of pre-existing or coexisting conditions. Safety profile characterized by short-term mild, moderate pain at injection sites. Incidence of serious adverse events was low and similar in vaccine and placebo groups. So as we're trying to communicate in real time to the public about these vaccines, we're drawing on the science and communicating these messages. But I want to point out that the science can be right, but still be incomplete. And it's the communicating of these kinds of complexities and ambiguities that's really challenging to the public. So we learned very quickly that antibody levels wane. Those phase 3 trials were very short-term efficacy. Rapid viral evolution. Both of these markedly reduced the vaccine effectiveness from what we saw in the phase 3 trials. Vaccine efficacy may be similar across demographic groups, but not all demographic groups had access to the vaccine or wanted the vaccine. And that was one of the huge challenges we faced in the COVID-19. And rare adverse events cannot be detected in phase 3 clinical trials. So we're messaging to the public that these vaccines are safe, but we only learn about rare adverse events like myocarditis or inflammation of the heart muscle, when many people are vaccinated. I found this quote by Milton Razanu around the 1918 pandemic, and I want us to kind of reflect and be humble about what we actually know. And he wrote, "We entered the outbreak with a notion that we knew the cause of the disease, Pfeiffer's bacillus. Perhaps if we have learned anything, it is that we are not quite sure what we know." And then I'll just end, but in an interesting twist, there are some people who speculate that that 1889 Russian flu pandemic may have actually been a coronavirus and not influenza. There's some interest, it's speculative, but there was a study published by Belgian scientists in 2005 where they sequenced the virus and showed that it was very closely a coronavirus. It's the OC43 coronavirus. Showed that it was very similar to a bovine coronavirus that was thought to be kind of an outbreak among cattle in 1890. So there's this kind of intriguing genetics, and then some of the symptoms, or clinical manifestations in the Russian pandemic, which remember was really the first one that was well documented. Older people died, young children did not, which is unusual for influenza virus. They reported loss of taste and loss of smell. They reported extreme fatigue, like long COVID type symptoms after. So again, it hasn't been proven. I know there are groups like Jeffrey Taubenberger's group who are trying to find old tissues from people and see if they can sequence the virus. So it remains speculative, but in kind of this weird twist of fate, maybe Pfeiffer actually was looking for a coronavirus and not influenza when he identified his bacillus. Thank you.
Thank you. I'm going to be echoing a lot of the same themes. It's really a pleasure to talk to you today. Real honor. I know it was mentioned where I work, the Center for Health Security. The person who founded that center was the late D.A. Henderson, who was a member of Delta Omega. He was also a former dean of the School of Public Health, and he led the smallpox eradication program for the WHO for over 10 years. And he, one of the reasons that, and this is a theme that I will have going through my remarks, is that, public health really needs to be ready for everything and anything. And so when he started the center, there was during the 1990s, there were reports of defectors from the former Soviet Union that there was a biological weapons program going on there that was illegal, and that smallpox was actually being weaponized and put into missiles. And he looked around at the U.S. and, how are we ready for this? And it was seen as a military problem only. And he said, if people get sick, they're not going to go to the army base. They're going to go to the hospitals. We're going to need public health to be able to deal with this. And so that was why he started the center at that time called the Center for Civilian Biodefense, because, you need to have public health involved no matter where the disease comes from. And so one of the things that he was obviously very much post 1918. So to go back a little bit further, there's a lot that was just talked about how we have to be humble about what we know and don't know, and how during 1918 the viruses were not even identified, and we feel sorry for the people that had to combat a disease at that time without even knowing what caused it. It took over a decade to be able to identify it. But there was actually a lot of really great science that was going on at that time. And they certainly didn't feel sorry for themselves about the state of science at that moment. It was all bacteriology. It had just been for decades the golden age of microbiology. There was new bacteria species or new bacteria discovered all the time. There were new vaccines and treatments for bacterial diseases that were identified. And Hopkins was a place where a lot of this work was being done, but there was a lot that was left unknown. And that is something that, we see today, and that we have identified the pathogen that has caused this pandemic, but why, how does it evolve? When people were talking about Omicron, people were concerned about it because it was much different than the previous versions. But you couldn't look at it and say, oh, this is going to cause a 10% increase in clinical cases. You couldn't do that because there's so much that we have left to know, to learn about viruses and how they evolve and where they come from and why they go pandemic. And so there's just a need for this humility to be able to think about how we can answer those questions. It may seem like there are a lot of barriers in the way to answering these questions for public health. We have now, having gone through the pandemic, there's a lot of anti-science sentiment. There's a lot of anti-public health sentiment, and people don't need to usually go much further than a relative or two to encounter this. But the other thing I want to impress upon you is to be persistent, that eventually the right thing will be done. And from there, I will draw a story from 1918. So before 1918, there was a Senator Ransdell of Louisiana. And I haven't looked into too much of his past because, honestly, this is the story I'm going to tell is really a good one, but I'm sure he had really terrible views on many other things. But his primary, he was really, he thought public health was something that was a national responsibility. It was not a local problem. It was not something for just doctors to be worried about. It was everybody's responsibility, and the nation needed to do something about it. And he pointed this out, that, the US was trying to build the Panama Canal after the French had really, really messed that up. And were really challenged by by disease, by malaria, and especially yellow fever. One of my ancestors died of yellow fever during the building of the Panama Canal. And, but it wasn't until mosquitoes were brought under control that it was able to succeed. And so that proved his point. We need to do something on a national level for public health. A little bit later, 1918 flu came through and, proved his point again. I mean, the world was at war at the time, and flu, this was not something that, was good for our military strength. It seriously degraded military forces at the time. There were some decisions made that made this worse, of course, but nonetheless, the disease really impacted our ability to exert our national security. And so that proved his point again. But, again, nobody listened to him. Nobody wanted to consider his bill that related to national public health. It wasn't until some years later that there was a bad flu season, not 1918 bad, but, bad enough to remember that, like, oh, yeah, this was not great. 1918 was terrible. And there's actually something we can do about it. And it was at that point that Congress finally considered what they could do to address public health. And that was when his act was passed in the late 1920s, creating the National Institute of Health. And so there's a long journey between the Panama Canal, 1918, and founding the NIH. It was just one institute at the time. But this is why you need to be persistent, and why public health, these messages are not going to go out of style. People may not want to always hear them, but scientifically based evidence that shows that we can do something about threats that threaten the public is going to remain true today, and the need to learn more is going to remain true today and tomorrow. So I hope that everybody will you're in a noble profession, and this is really important work, and people are going to remember that it's important work, just maybe not today. So thank you very much.
Okay. Are there any questions in the chat in the Zoom right now? Does anyone know? Not yet. Okay, great. Well, I think you never know exactly what your fellow panelists are going to say until they speak, but I think our presentations really fit together very well. So I was going to start with the question, this question of how do we show people what public health is and what can it do? And I was wondering if each of you could speak to that as far as, what are some of the most important, teachable moments during the COVID pandemic, and what might those moments show us as an example for the future?
Shall I start?
Mm-hmm.
Well, it's a very important question, and you alluded to the fact that we're living in a time of mistrust by many people of science and public health, and so it's very important for us as public health professionals to try to communicate the value of public health to the public, and some of the teachable moments may be teachable to some audiences and not others. I think it's difficult, and so we do need to be able to kind of craft our messaging to the right audience, or to different audiences. I'll say, I'm biased towards vaccines, but I'll say, the rapid development of effective and I'll say relatively effective and relatively safe vaccines, and the ability to show the impact of those vaccines on, particularly on mortality, but hospitalization, disease is really important. You had mentioned, Karen, about one of the key tasks of public health is counting, and so being able to show and count deaths amongst those who were vaccinated and those who were not vaccinated, and what those different rates mean, to me is a really powerful testimony to the science behind the vaccines and the ability of public health practitioners to get the vaccines into arms, and public health professionals to actually measure the impact. But that, I know those data don't convince everyone. And so we have different audiences to target our messages to. Maybe Gigi.
Yeah, I think targeting messaging and studying how messages land is really important. The underlying facts can be presented in different ways, and we want to make sure that people are getting reached, and that those, and that we're putting enough funding into that, because that's often what gets cut out, and that's of course that last bit is really important for people to actually hear. I worry a little bit that the next few years are going to be so shaped by COVID that we need to remember that there are many other threats out there, that we are not going to be able to create a vaccine in such a short period of time. We were not lucky at all with COVID, but at least a vaccine was possible, and that might not be the case for some other viral threats.
I'm just going to add, I flew up from Atlanta this morning. I was attending a global measles and rubella laboratory network meeting, and we are seeing increasing measles outbreaks. This is a disease for which we've had a very safe and effective vaccine for decades, and a real shout out for the need for public health interventions and preventing measles outbreaks, because measles is coming.
Yes, what's that question?
So Sarah asked, how can we better integrate public health with the economy, business, and climate change? So bringing public health to the forefront of our economic prosperity and environmental stewardship.
Okay, could everybody hear that question? Okay. So that's a very interesting but hard to answer question.
One way that I think this should be answered is by having people who know something about public health in these different sectors. And having that cross-pollination of expertise is really critical. I see this a lot with science, and how even if somebody's science, actually holding a pipette in their hands days have been, quite a long time ago, having a person who appreciates or knows the process by which science is created, how it works, and how papers are published and so forth, having people like that in positions of power makes a big difference. There once another person that DA was actually close with, and is General Phil Russell, who led the program to create the smallpox vaccine at HHS post 9/11. And he was a major general in the Army, not a major general in the public health service, a major general in the Army. And so when he met with other generals, he would be able to share his expertise and influence decisions that were not related to public health, but had public health impacts. And so I think that having people who have public health degrees have a power in other realms can make a big difference.
Yeah, I would really agree and second that. And when we look at public health alumni, what always is so interesting to me is to see how many different places graduates end up. I believe there was a biostatistics alum who ended up being the, did she work for Etsy, Marie? Do you remember who I'm talking about? Yes, and what was her position? I can't remember.
She was a statistician with.
Right, so there's just a need for expertise in all. So the interdisciplinary nature of public health helps it to really get out into the world in a way very few other disciplines can. Megan, I would actually invite you to talk about the idea of One Health, which I think is very applicable to this question. Would you like to?
Sure.
Yeah.
Hi, everyone. So I'm Dr. Megan Davis. I'm a way past president of Alpha Chapter of Delta Omega. It's so great to see everyone today. So I also do a lot of work in both One Health and Total Worker Health, which are disciplines that bring together disciplines. I mean, the entire purpose of these is to have integrated approaches and to consider how you bring people together as a foundational skill that is essential for the activities that we might need to do to prevent spillover, to address rapid response to outbreak situations, and many other public health challenges. And so I think that when we think about how we do the work of public health, remembering that it's also about the language we use and the people that we connect with and how we consider to mentor leadership within these constructs. And that, of course, is something that we value in Delta Omega as well. So thanks.
Yeah, as a side note, so one of the faculty who helped found Delta Omega was William Henry Welch and William Henry Howell. And I always joke on my school tour that if you want to be dean of the School of Public Health at Johns Hopkins, you need to be named William Henry, preferably. But William Welch is a very interesting example of someone who really had very close connections with, he's most known as a bacteriologist and a pathologist, and he had an MD, but he also was so in tune with the concerns of the people of Maryland that he was most loved by the people of Maryland, not for being the founding dean of medicine and public health at Johns Hopkins, but because he had saved their hogs from hog cholera. His expertise, he had very freely shared that. And so I think in, kind of going back to this question of, it was about how public health and climate change, and that being able to show your usefulness and your passion to help a wide variety of sectors. So not just academics, not just bench science, but doing things like going out to the hog farmers of Maryland. And what that did was that created a lot of political capital that he used the rest of his life. So anyway, there was. Yes, oh, please, yes.
So we'll try to get this up or not. So Kellogg Schwab, I'm a professor here in Delta Omega. This is wonderful. And my question to you is, as I hear these things in there, I always say wash your hands, right? That's been my across the board. And my question is how do we build on this? It feels almost like deja vu every time that we're starting from zero. And I know personal protective equipment can save lives. I know that, and some of our healthcare providers did not have that adequate first responders in there, and that was devastating. How do we jumpstart this so that, and this is to the preparedness side, that we don't have to start from zero, that we can have an acceptance of this is at least a baseline where we'll work forward for whatever unknown it may be. I'm a water guy. I respect air transmission in there, but water is still an important part of that, and sanitation as drivers in there. What do we do? What do we do as public health practitioners and our students to that next level of pushing this so that we don't have a repeat, seems like every time, of having to be on our heels defending the basic principles, but can move forward to be aggressive to address the challenge that's coming forward to us?
That's an excellent question. And I'm going to give a quick, what might seem like a weird example, but when I was in college, I worked very briefly as an intern for the Strategic Petroleum Reserve. We have a stockpile of oil under the ground in Louisiana in case there's ever another
oil crisis or war or various other things that might cut off the oil supply to the United States. That happened in 1972, and we still have that stockpile. Now, to Kellogg's question, we need a PPE stockpile. Do we have it? Does anyone know if we, in 2024, have an organized stockpile that could be deployed quickly?
So I was trying to think of how we could, like, in public health generally, how we can avoid doing this every time. And I think there's a lot of value in the boring details. And so there have been some good changes that have been made to the stockpile, which was pretty bare when COVID started. It's a long story, but it, I think that it's in a better spot now, and I think there are people who are working towards making it better. But I think getting into the more boring details of how we can make things go smoother and why we can fund things is where we can get more agreement than when it gets up to a higher level of, like, I don't want to share my data with CDC and like that kind of that kind of stuff. So I think there's some good work that is being done on diagnostics, on stockpiling, on some things that are a little bit not as central to political conversations, and how we can keep this from happening again and again and again. I'm not sure, except that we just have to keep being persistent and try and have stable funding for public health. But I don't know how that's going to happen without another couple of reminders.
Bill, I'd like to give you the opportunity, but I'd like also push back a little bit. It's not pushback, but it's, if we do our job, no one appreciates it, right?
Mm-hmm.
The goal of my job is to not have to go to work because we solved all the problems. That's not tenable, but the idea behind this is not just in that preparedness for ourselves, but then the community side of the thing of what is valued. Mm-hmm. Back to vaccines. Why is there, vaccines save lives, right? Hand washing saves lives, but we still have to be on our heels on that. So it's this preparedness I get, and I understand that, but it's also, what do we need? We need to think differently, because it seems to me that what we're doing right now and potentially in 2024 to 2029 is got to be a almost radical change of thought process. And maybe it's messaging, maybe it's other things in there. I don't know.
Yes, I'll try, but I'm a William John, so I've just given up my aspirations to be dean. But I agree with you, Kellogg, and what I often say in classes is, successful public health programs undermine themselves because then the disease is no longer visible. And so I would say, we need to do a better job of keeping the visibility of public health in its successes when the disease is not there. And again, I'll go back to measles, my favorite disease. I was just as I said, at a meeting where people were talking about, making sure the policymakers, the politicians are aware of, the benefits of measles vaccines. Even if they're not seeing measles as a disease, they have to understand the benefits. So I think it is around communicating and messaging outside of it, in between pandemics, in between outbreaks, to give public health that visibility. And again, even in the absence of disease, that this is the success of public health. But I think that's the challenge of the messaging. Yeah.
Any other questions from the Zoom chat? Yes, please. Can you come up to the microphone?
Hello, everyone. So it's just a little bit of a comment, actually, on the last thing that you said. You mentioned something about politicians. So I wanted to just ask, how do we effectively sort of engage with politicians when we talk about the message of public health and bringing people together and public sort of mistrust? Sort of what comments or maybe examples you have of like being able to effectively engage with politicians on this note? Thank you.
I mean, we do this a lot. We try to provide information to politicians and to try to offer good policy, scientifically based policy evidence. I think that at the end of the day, politicians just want to get elected, so you have to give your message to multiple people. But yeah, it's I think that it's important to keep that it's their job to help protect the public. So I mean that is and if it's not their job, they shouldn't be having that job. So that's so
Wow.
my other comment would be that more people in public health should run for office.
Thank you.
I'd like to make one more comment before we go. Do we have? Oh, I thought you had a question. So one of the things that we've barely touched on, but it's kind of a theme in the first, in both pandemics we're talking about today, is the military. And, the influenza pandemic in 1918 started on a military base. And when you look at the old photos, you see a lot of people in uniform who are both patients, but also a lot, they really mobilize the military to try to help care for the patients. And then in 9/11, of course, there's a strong military connection with this surge of support for public health, but it was in a defense context. And, so I'm a 20th century historian of public health and medicine and race and various things, but what kind of this idea of what is the thing that can unite everybody to support public health? What is the thing? And we really, it's a difficult legacy that the thing in the 20th century that got everyone to support public health was the Cold War and defense. And I'm glad the Cold War is over. But politically, so for instance, the CDC's Epidemic Intelligence Service, why is it named that? Because it was founded immediately after the Central Intelligence Agency. And there are so many examples of, and I would say that politicians did this very interesting, I would call it policy jujitsu, where they would really want one thing. There were politicians who were trying to pass national health insurance all the way back in the 40s and forward. But they didn't say, we want to pass national health insurance because it's the right thing to do and we really need to take care of all people. They would say things like, this will improve the productivity of workers, and so all I'm trying to say is there's a lot of different strategies and there's a lot of different things we could link public health to try to get more support, but none of them are perfect and a lot of them are problematic. So anybody else want to comment on that as far as what's the thing?
I can just pick up a theme you mentioned, Karen. Last week, I think it was last week, I participated in a roundtable discussion at the Center for Strategic and International Studies on measles vaccine as a national security threat. And so, and that's an organization that grew out of the Cold War. And so, I think you're right. There are these kind of different platforms, different ways to frame the benefits of public health. But as a national security threat, maybe that gets some of the politicians who were trying to get the ear of. Yeah. Gigi probably has experience with that too. But
are we at time? Yeah. So we're at time. I just want to thank everyone. I'm sorry. Oh yes, please, by all means, please give us.
Jones, and I'm asking this question self-certainly in my role as Assistant Dean for Community Engaged Research. 2% of Americans have a PhD. A little over 20% of people with a PhD have a parent who have a PhD, which some speaks to how insular we can be in the type of work we can do, and it includes our family and our communities. Do you have any suggestions on how we step out of our insularness? And I think one of the things that we need to do in order to help level set some for public health is stepping out of our insularness and talking to ourselves and bringing other people along as a part of our community. So I would welcome your suggestions on how we do that.
Maybe I can start. It's a very important question. And again, I'm going to use my vaccine world, but I think the vaccine world is a community that that very much recognizes not only the importance of getting the message right, but of getting the messengers right and having the right champions and advocates in the community. And these can be faith-based leaders, and there are great examples of that. The vaccine community engages with civil society organizations around the world to try to promote and advocate and facilitate access and demand for vaccines. So there are ways to do it, and there are successful examples, but it is something I think we need to do more of and do better at, and do it continually. To come back to Kellogg's point, it can't just be during crisis mode. We need to have that full engagement as a continual process.
Just to add a little bit about disinformation and misinformation, I think we talked a little bit about it, but it was very well financed during COVID, and it was really hard to combat against. And I think that that is a big barrier that we need to address, so that we can have public health messages go to and inspire people to go into public health and to at younger ages. But I think it's a barrier that we're going to need a lot more than public health to address, just given the amount of money that goes into it.
Vanya, that was just such a good question, and my answer would be, we need to. As public health professionals and academics, or both, we have a lot of things that we're supposed to be doing, especially if we don't have tenure yet. But, but for me personally, I'm just going to say, 2 years before the pandemic started, I moved from Baltimore County into Baltimore City. That completely changed my experience of the pandemic. And it made me, I was already very sympathetic to what Vanya's talking about, the importance of getting more people who have never even thought of getting a PhD, to go into academics and go into research and teaching and all of those things. But I'm now in a position where, when I really understood what was happening, I was able to go to the pastor of my neighborhood church a block from my house and say, I think we need to ask people to start wearing masks, and we need to provide them at the front of the church. And when you have the kind of community relationships like that, and you can do that in all sorts of ways. You don't necessarily have to live somewhere, but find enduring connections with the communities that you want to serve, and also that you want to build a bench from. In other words, like a baseball bench. Like you want to supply, your organization or your university or whatever. You need to have those kinds of really intimate connections and build trust and be a part of their world and make it your world. And that's, that's what I was able to experience just by moving 3 miles, but it was a tremendous distance in a lot of ways. Mm-hmm. So are there any other closing comments today? I think this has been really fascinating. Thank you so much for coming, and take care.